All right. I spent almost five after, and I think most everyone joined in the first couple minutes. So we can go ahead and get started. I'm Dr. Kimberly Thornton. I'm one of the reproductive endocrinology and infertility specialists here at RMA of New York. I primarily work in our downtown office in Soho, but we do have locations on 60th and Madison Avenue on the Upper East Side. We have a Midtown West office on 57th and 8th. We have an office in downtown Brooklyn, Westchester offices, and Long Island. So we're throughout the whole New York area. And today we're going to talk about egg freezing. So I usually just kind of start through like, what is egg freezing? Why some people start thinking about freezing their eggs? What's the process like? To kind of go through all of that information. And at the end, if you have any questions, feel free to put them in the chat. We can do a question and answer session and kind of go from there. So we always worry about fertility, and unfortunately, especially for women, with age and time. And a lot of that is because how our biology works is we are born at birth with every single egg we're going to have. And we never have the ability to generate or make new eggs. Now, everybody is different. Some people lose eggs a little bit faster, some people a little bit slower. But for the most part, most individuals start out with about 1 to 2 million. And when we lose them as we age, and unfortunately, at some point, we all hit menopause, which is when there are so few eggs remaining that the ovaries essentially fail. Our ability to conceive naturally ends at that point, which is usually late 40s, early 50s. The other big age-related factor, though, that starts kicking in much sooner, and why we worry about fertility well before these menopausal years, is that the quality of our eggs also goes down with age and time. Those eggs have been there since birth. And so as we get older, the eggs essentially are just sitting around longer. And when they fertilize to become embryos, they become much more prone to making embryos with spontaneous genetic abnormalities, things that are not inherited, that don't run in families. So, for example, like a healthy embryo should have two copies of all of its 23 chromosomes. So we usually get 23 chromosomes from the egg, 23 from the sperm, and then they get together and line up in pairs. And that's what we want to see in a healthy, potentially viable embryo. Sometimes during all that rapid growth and division early on, mistakes happen. And sometimes an entire chromosome gets deleted out, an extra one can get added on. But there are thousands and thousands of genes on each of our chromosomes. So if all of a sudden thousands of genes is triplicated or missing, it's really abnormal, to the point that 98% of the time that embryo will never be a live birth. Like, we usually don't even get positive pregnancy tests. Our bodies do a great job of filtering these abnormal embryos out. If we do get pregnant with an embryo with one of these abnormalities, it is the number one cause of a miscarriage in the first trimester of pregnancy. And then Down syndrome, which is three copies of chromosome number 21, is one of the very few. It's in that 2% of these abnormalities that potentially is compatible with life. It just tends to be a smaller chromosome. So we see individuals with that disorder. So people tend to be more familiar with it. We don't see anybody, there's never been a reported live birth of three copies of chromosome 1 or 2 or some of our larger chromosomes. So truly, when we start saying the quality of our eggs declines with age and time, what we actually mean is the percentage of embryos that we start producing with missing or extra copies of chromosomes, most of which are non-viable, is starting to go up. And the really challenging part of all of this is there is no test for egg quality. It does not exist. There is no way to test someone's blood and say, okay, like, your eggs are better or worse than the average, 35-year-old or average 37-year-old or 32-year-old. It is strongly linked to age, much more than egg quantity, which we'll get to in more detail in a little bit because we can measure quantity. It is more rare for people to fall outside their age categories for quality, so I can at least give age-based percentages. In general, individuals under 35 tend to have the best quality eggs, lowest amount of these abnormal embryos. I would say even under 33 is even the best, even slightly better. It is still under 33. It's like 25% of embryos on average will have one of these abnormalities. So, at low frequent baselines at all points of our lives, these errors occur. It's somewhat a part of the reason we don't always get pregnant every month we try. It's unfortunately why so many women experience at least one early miscarriage in their lifetime, especially if they have more than one pregnancy. But most of the eggs yield healthy, viable embryos at that point. Around 33, 34, we start seeing a little bit of upticks, not huge changes, but it can get closer to about 30% of embryos have these abnormalities. At 35, it's closer to on average about 40% of these have errors. By 37, it's about half of our embryos are making these abnormalities. But by the time we're in our early 40s, 41, 42, it's easily about 80% of embryos have these abnormalities. And once we're above 43, it's over 90%. And that truly becomes the number one reason it is so much harder to get pregnant with age and time is yes, like the quantity or the number of eggs is getting lower and lower, but it's really also the quality of what's there that matters, I would say, more than anything, that becomes so poor that it's harder for things to line up. And the problem is we can't reverse these changes once they occur. We have no prescription or supplement medications to any significant degree that has ever been shown to significantly improve egg quantity or quality. And even things like IVF success rates, we see on average, once we're above 43 in the United States, is only about a 5% chance of a live birth per cycle because there are so many poor quality eggs left at that point. So, the main benefit of freezing, or why some people start thinking about this as an option, is it keeps the quality of the eggs the age we freeze them at. So, depending on, when somebody thinks they're going to start their family, how many children they may want to have, how many years they plan to space between those pregnancies, or for some people who have no sense of what that timeline could be, and there might be some realistic probability that any child desired could be in those late 30s or 40s. Sometimes freezing can be very beneficial because if someone ends up struggling to get pregnant later on and they have eggs frozen from a younger time frame, we're working with a better quality set of eggs who are more likely to be successful. And so that's sort of kind of what leads us to this process and why some people start exploring it. Egg freezing is unfortunately pretty much all injection medicine. So they're like little shots that go in our belly. And usually, if somebody wants to freeze their eggs, we typically start around the time their period comes that month. So the first day of your menstrual cycle is day one. We usually start those medications around the second or third day of the cycle. If somebody is on birth control pills, they do have to go off the birth control pills to freeze their eggs. They do not harm fertility, but birth control pills prevent eggs from growing, and we're trying to get them to grow. So usually people have to be off of them at least 4 days before starting the medication. Sometimes if someone's been on them longer or based on their test results, it can sometimes be recommended to go off of them for a longer period of time, like maybe a month prior to starting. So that's usually an individual conversation to have with your physician. IUDs can stay in place. Someone still ovulates when they have an IUD, and it does not have to be removed to freeze eggs. Some IUDs, people do not get their menstrual cycle, so it can be a little bit more tricky. Often more blood work is needed to kind of figure out the right timing. But let's say no IUD, no birth control pills, we usually wait till your natural cycle starts. It is unfortunately pretty much all these injection medicines that go in your belly, and people are on them for about 1 to 2 weeks. I would say in general, I never see anybody ready in less than a week. So mentally, I always say prepare for at least a week of injections. It's typically not longer than 2 weeks. But when you start, the really hard part is we never know the exact day your eggs will be ready to be extracted. And so, usually, when you're on these medications, you have to come for an ultrasound and blood work every other morning so that we can get a sense of when the eggs should be extracted. On ultrasound, what we're looking at is something called follicles. They're these little black circles on our ovary, and they are fluid pockets. One egg is floating in each one of them, and they expand. They become big black circles. These fluid pockets get more fluid in them as the egg inside is maturing or having that ability to fertilize. So the size on ultrasound is a huge determinant on the day we should extract the eggs. And eggs make hormones. So we're always checking your hormone levels in your blood so we can see how to titrate up and down your medications along the way. Usually at RMA, we typically do those check-ins early in the morning, depending on our office, and it's usually roughly somewhere between 7 and 9 a.m. to try to not interfere too much with the rest of the day. Once those eggs look ready, or those follicles that the eggs are growing in, we have you take something called a trigger medication, and then that's when we schedule you for an egg retrieval, which is always not the next day, but the day after. So, meaning, let's say today is Wednesday, if someone's freezing their eggs and they came in for their ultrasound this morning and they're ready to take their trigger medicine tonight, that means the egg retrieval would be a Friday morning so that you have a little bit over that definitive 36 hours notice and planning. But egg retrieval is a day that you don't want to have any big event that you need to go to. If it were like a work day, you would want to make sure you could take off of work. And we do all of our egg retrievals at RMA in our operating room. That is either, if you're in the Manhattan, it's at the Upper East Side location, or we do have an operating room in Brooklyn and another one in Westchester and Long Island. The procedure is very quick. It's 20 minutes start to finish. Our anesthesiologist gives you a little twilight anesthesia, so you take a little nap. It's not general or major anesthesia, but people typically don't remember the procedure. And while you're asleep, we place a needle through the wall of the vagina under ultrasound guidance, and we drain all those little fluid pockets, those follicles that the eggs are growing in. And underneath the microscope in the embryology lab, the embryologists are going to go through the fluid and count out the eggs. We usually can give a rough count of the number of eggs extracted before somebody goes home. And most individuals are ready to go home about an hour after the procedure. It's rare to need narcotic pain medicine by the time someone goes home. Most people are okay with things like Motrin and Tylenol, but you will feel a little cramping and bloating for a couple of days where you might need some Motrin and Tylenol for a few days. Most people, as long as you have more like an office job, nothing too physically active, most people can go to work the following day. We know a rough estimate of the number of eggs extracted before you go home, but we don't have the final update on the number of eggs frozen until the next morning. The eggs come out, they have a lot of cells, debris on them. The embryologists really spend the afternoon, they clean off each egg, they examine them. They're checking to make sure that the eggs have fully matured and have that ability to fertilize, because unfortunately, on average, almost 20% of eggs never fully respond to the medications. So from that initial group extracted, there's usually some that will not be able to be frozen, and we get that final update the next morning. And then we're done. No more medicines, no more check-ins after the egg retrieval. Most people get their menstrual cycle about 1 to 2 weeks later, and then their cycles just reset and go back to their normal natural cycle. Or if somebody wanted to go back on their birth control pills, that's, if you were on them, that's the time you can restart them. So the science behind what we're doing with egg freezing, because then it makes the testing and all this stuff make a lot more sense, is kind of back to that we are born with all of our eggs. And a way to think about it is they're sort of like locked away in a vault in the ovary. And each month from that pool of eggs in both of our ovaries, our body naturally releases a small group of eggs to the surface of both ovaries. Normally, without fertility medicines, our bodies panic. Like, we are not puppies, we are not kittens, we should not be having 5 babies at once. So, our brain normally only releases enough hormones to allow one of those eggs to grow, ovulate, and release. And then we typically just discard and get rid of all the other eggs from the group. So, what we're doing with egg freezing, all these injection medicines that we give, are the hormones that the pituitary normally releases to grow the one egg, but at higher doses to try to get the whole group of eggs to grow. We essentially are trying to rescue those extra eggs that our body naturally would discard that month if we hadn't grown and extracted them. This is truly the benefits as well as the limitation of the technology, I would say, all wrapped together in one. The benefit is this is why you don't go through menopause early if you freeze your eggs. Like those eggs were going to be lost, whether we extracted them or not. It's not going to deplete somebody's ovarian reserve or egg count. The limitation is our medications can only grow on that group of eggs that your body naturally started to grow that particular month. And this is why it's very variable. Why some people have a friend that got 4 eggs and their other friend got 18 eggs. This is why it is physically impossible to get thousands of eggs per retrieval cycle. And this is truly what most of our testing is looking at for egg freezing, is to get a sense of how somebody would likely respond to medications, what range of eggs they're likely to be able to extract in a single retrieval cycle. And this is strongly linked to egg quantity, which we can measure. Quality we can't, as from the beginning, we talked about that. Quantity we can. And we usually assess it in 2 different ways. One is a baseline pelvic ultrasound that we typically do at your new patient appointment to look at the ovaries and count those follicles, those little black circles I keep talking about. Because by counting them, I can tell somebody how many eggs their body released that particular month or cycle, because it's usually very similar in short time frames. And so, based on ultrasound alone, we can often give a good sense of what someone's egg count looks like and a range of eggs that they're likely to extract in a single retrieval cycle. The other is a blood test called an AMH level, which stands for anti-Müllerian hormone. It's a hormone made from eggs, and it tells us where somebody's at on losing them. Like, are you average, above average, or below average? You have to take it with a grain of salt. People tend to panic when it's low. They often think, oh my goodness, I'm never going to get pregnant. This means I'm infertile. People often feel overly reassured when it's high. I think I have nothing to worry about. I never need to freeze my eggs. And neither of those are exactly true. It doesn't actually tell us anything about somebody's ability to get pregnant naturally. And that is back to the puppy and kitten analogy. If somebody is 30 years old and they have a million eggs left in their ovary in that reserve, and somebody else is 30 years old and they have 3,000 eggs left, well, both people are still only going to ovulate 1 egg per month. And when we put people in the same age group, the quality is typically the same. So it's really well studied. We don't see that people with low counts are less likely to get pregnant naturally, and someone with a high count is not more likely to get pregnant. The only reason we care about it, the only thing it actually predicts, is how many eggs we are likely to get in a single extraction cycle for egg freezing and IVF. Women with higher AMH levels, meaning they have more eggs left in their ovary, their bodies essentially have more eggs they can afford to lose. So they naturally release larger number of eggs to the surface of both ovaries each month. So they tend to be a little bit more sensitive to the medications. They can often get away with lower doses, and they're more likely to get larger number of eggs per extraction cycle. Like usually I would say 10 to 15 eggs is what we would consider a solid response. So someone with a good count is often going to get that in a single retrieval cycle. Somebody a little bit above average might even be getting above that. But once we have less eggs in our ovary or lower AMH levels, our bodies really start conserving, holding on to our eggs. We start releasing lower numbers of those follicles each month. Our bodies, in a sense, try to slow down how quickly we lose what we have left. And the ovaries start to become much more resistant to the medication. So those people tend to need higher doses of medications. They're more resistant to the medicines, and they often get lower numbers. Like sometimes truly 4 or 5 eggs is the best we're going to be able to do in a single retrieval cycle. So egg quantity tells me medicines and protocols that would be best for somebody's body. It helps me give them expectations on a range of eggs that we could likely extract if we're talking about egg freezing. But it doesn't tell me who will or will not get pregnant. Unfortunately, no test can tell us if someone will get pregnant now or 5 years from now. We don't ever know for certain until somebody starts trying to get pregnant. The one realistic disadvantage, however, though, of a lower count is that that person realistically, depending on what their goals are, may want to think of doing more than one retrieval cycle to bank up a higher number of eggs. And that is because we always encourage people to have this large group of eggs frozen, Because when we freeze the eggs, all we can tell you is how many there are and if they matured, meaning they could fertilize. Not that they will fertilize or that it's an embryo that will implant or that it'll be a healthy embryo. And we know that the numbers funnel down. It is like an inverted pyramid from the egg to the embryo stage. There is often, on average, I would say a 60 to 70% drop off from what makes it from an egg to what's called a blastocyst embryos a week later. And then based on somebody's age group, out of that group of embryos, we're still, when we test them, because we can test at that point, going to get a percentage of abnormal embryos, so which can be, as I would say, on the lower end, maybe 25%, and on the higher end could be 80, 90% abnormality rate. So depending on your age, which is definitely a very individual conversation to have, so we always recommend if you're thinking of freezing eggs to make a new patient consultation to have a one-on-one conversation with a fertility specialist. But based on your age, there's always going to be a recommendation of the goal number of eggs that you should have for best chances to get one live birth. And then depending on how many children you're trying to freeze for, you want to factor that all in if there's a good chance that you might need your frozen eggs for every pregnancy, or maybe you're starting think you'll start your first pregnancy at an age where you might need them and we're just freezing for a second pregnancy or depending on the goals. But I would say in general, we usually always recommend, even at young ages, not trying to have a goal of at least above 10 eggs frozen to account for this funnel down. Out of eggs frozen, if you ever need to go use them, first step is to thaw them. So on average, about 85% survive thaw. So we often may lose an egg or two just to the thaw. Then we would take partner, donor, whatever source of sperm you want us to use, and we put the best looking sperm directly into each egg to help boost fertilization rates. And 24 hours later, we look under the microscope and see how many fertilized normally. And usually about 20% do not fertilize normally. And that's typically with normal sperm parameters. So if there is ever a partner that has issues with their sperm, we almost always get lower fertilization rate and poor embryo development. Everybody kind of focuses a lot on the eggs sometimes, and we forget that the sperm is the 50% of the genetic pool. It's 40% of couples that struggle to get pregnant. The sperm is a leading or major contributing factor. So sometimes when we freeze our eggs, we just don't know what that piece of the puzzle is going to look like at that point in time. And out of the ones that fertilize normally, we watch them a week later to what's called a blastocyst stage. And usually only half of the ones that fertilize normally make it to that point. And that is when an embryo is a little bit over 100 cells. We can test them at that point. We can take cells from the placenta, sequence the DNA, say, okay, this is a healthy XX female, healthy XY male. No, this one's missing or has an extra copy of a chromosome. So we can gather a lot of information, but not until that stage. And even genetically healthy embryos are often usually somewhere between a 50 to 70% chance of a live birth per embryo. So it's good, but it's usually why the goal is to try to end up with a couple healthy embryos, because that's what gives us those high odds and statistics of a live birth. And so let's say someone's only able to get 4 or 5 eggs per retrieval cycle. It is because their count is lower. It is going to be in their best interest to do another cycle to bank up those higher numbers to account for all those funnel down steps. That is unfortunately also why, though, egg freezing does not guarantee a pregnancy. So some people truly 5 eggs is enough and they're going to have a live birth. Why some people may need 20 eggs before they'd have enough embryos to have a live birth. And so we never know for certain what it's going to funnel down to be until someone thaws their eggs. And even if we know how many embryos, we don't know until we go to transfer one back if it's going to implant for certain. So egg freezing is truly a technology where there is safety in numbers. The more eggs you have frozen, the better chances you have of achieving a live birth. And the younger somebody freezes their eggs, the less eggs they need frozen, because we're freezing better quality eggs. And so we also see the best success rates the younger, like when we freeze at younger time frames as well. As far as side effects of the medications for egg freezing, they cause the ovaries to swell. All those fluid pockets we were talking about expand. So the ovaries essentially go from the size of like 2 little lemons to 2 big oranges. So most people feel that. Their pants feel tight, they feel puffy, full, kind of feel like you ate too much. It is just water weight and swelling. It does go away. It usually takes a full week after the egg retrieval before we typically see it resolves completely. We don't recommend doing any strenuous exercise or physical activity when you're on the medication. So you could walk or ride a bike, not like an exercise bike where you're jumping it all around the place, but just like pedaling. But you really want to avoid a lot of running, jumping, core abdominal work, things that could aggravate your ovary while they're swollen. We don't want you to injure your ovary during this process. So you have to take it easier. If you're like training for a marathon, it's not the right time to freeze your eggs. Um, and those are usually the main things people sort of ask me about egg freezing as sort of an overview of the process. So I was going to open it now. If anyone had any questions, they could type them in the chat, and I'm more than happy to answer them. And then usually if someone has a very individual question, or if you kind of want to see your testing or where you're at, that's the best thing to do is making that new patient appointment. It, doesn't mean you even have to freeze your eggs if you're on the fence, but that way you can we can go through your medical history, go through your testing and give a better picture of everything. And it looks like we have, okay, so one of the first questions we have is I've heard mixed things about the increased risk of cancer from egg freezing treatments. So there actually is not a strong correlation or proven link between the medications, because the medications we use for freezing eggs are the same as IVF. And so we've been doing IVF, meaning, like, I guess to back it up a little bit, egg freezing is really the first half of IVF. How the growing and extracting of the eggs is identical for both procedures. The difference is IVF, after we extract the eggs, we fertilize, make an embryo right away, and transfer the embryo back. So egg freezing is like being on a train, and it's the first stop off where we freeze there. So we've been doing IVF for over 40 years. So that's where I would say most of our data is for these medications. Egg freezing, I'd say, has probably been more around the last 15 years is it's become more common. So in larger studies, we don't see a strong association. It doesn't seem to increase that. I think where we get a lot of that concern is a lot of people worry with breast cancer. And some breast cancers are hormonally receptive positive, meaning things like estrogen and progesterone can make them grow faster. And so there is a risk, let's say someone had an undiagnosed breast cancer that was hormone receptor positive and they were on the medications, it can make that cancer grow faster. But we know that the medicines, I guess, don't cause the breast cancer, if that makes sense. So it's why, if somebody is above 40 and doing this process, we always recommend having their mammogram before doing it. Or if there's a strong family history of things like breast cancer, where you should be getting screened earlier, that you do that. But we do actually fertility preservation quite commonly for individuals with cancer before they undergo chemotherapy, to help preserve their fertility, for breast cancer and all sorts of other cancers. Another question is, can I transport my frozen eggs if I move out of the country at some point in the future? Um, your eggs can always be transported. So they are frozen in liquid nitrogen. So they do have to be transported in special transport tanks. So typically people have to hire like a company that has these tanks where they can stay in the liquid nitrogen and transport them. I would say it is definitely easier to transport within the United States. Some countries, so I've had patients able to transfer their eggs to other countries, but it depends on the country. And so some countries have laws and regulations where they will not accept frozen eggs or embryos from another country. And so it really depends on where you are going. You'd have to be established with a fertility center there that also would be willing to accept the eggs. For an embryo transfer, like the thawing, creating the embryo, that's all mostly stuff done in the lab. The actual physical part of transferring an embryo back is about a 10-minute procedure, more similar to a pap smear than anything, where we place a speculum and then slide a little catheter through the cervix and leave the embryo in the uterus. And then the pregnancy test is 9 days later. So I've had some people who've moved abroad. If it was too difficult to transport their eggs, embryos, whatever the gametes they have in storage, I've had some people where it was easier just to come back for a couple of days for the transfer. So I think it really depends on where you end up moving, um, but it is possible, but it just depends on which country and their rules and regulations. Um, do patients with polycystic ovarian syndrome have less success with the procedure and drug reaction? So, PCOS, or it stands for polycystic ovarian syndrome. It's a metabolic disorder, especially people tend to have very irregular menstrual cycles and periods. Most women with PCOS are actually a little bit more sensitive to the medications, meaning it's more common that we get higher number of eggs with PCOS, but again, everyone's an individual, so not always. So it's more typical that people need lower doses of medicines with PCOS. It's more common that we get higher number of eggs. So we often use special trigger medicine called Lupron to try to lower side effects, because most of the side effects are if lots of eggs grow. But women with PCOS still very much have success with the procedure. They typically do respond to these medications. And a question is there a benefit to going off hormonal birth control pills more than 1 month or so before doing the retrieval? Does it impact the number of eggs you can get? So, birth control pills, how they work is back to that your eggs are in this vault, and then each month that small group gets released to the surface of both ovaries. And without fertility medicines, without birth control pills, your body is going to release hormones to grow one egg when and the others get discarded. When you're on the birth control, it blocks your brain from growing the one egg. So the whole eggs group come and then they get discarded. So it doesn't help your fertility. It doesn't keep you from having eggs, but you don't lose more eggs, or they don't get, lost at a faster rate. So that is why it kind of keeps things status quo. So most of the time people actually can just stop the pills 4 days before they start, and really we don't see any differences. The studies show that there's no difference in number of eggs extracted or frozen between people who stay on birth control pills versus people who go off of them for longer periods of time. Now, some people, though, have been on birth control for years, like maybe 15 years. And so sometimes the ovaries can get a little bit more sluggish, a little bit more sleepy from all those years of being kind of told, don't grow an egg, don't grow an egg. And so sometimes we have a hard time seeing the follicles. Those little black circles can be extra small. Sometimes we even see a little bit of suppression in that AMH level that can come back up once somebody goes off birth control. So we do know in those situations that people are often on the medications for longer periods of time, meaning it can take a couple extra days before things take off. So sometimes we might recommend going off of them so that you have a little bit quicker stimulation. Or if it's been a really long period of time, we may say to go off of it even longer than the month. But there's usually not a huge, if you're going to go off of it, I would say there's usually not huge differences between being off of it like a month versus 6 months that we would expect to see any sort of big difference. For people who have low egg counts, meaning they don't have a lot of eggs, sometimes we will recommend going off if they've been on the pill for a long period of time, just because we don't want anything else that's going to make their ovaries a little bit more resistant to the medications. But even with low counts, the studies have shown that the outcomes are pretty similar, whether you're on or off of it. So it's a conversation worth having, in the sense we also, if someone's using it as contraception, don't want them to have an unintended pregnancy. But if somebody is thinking of going off of them anyways, you don't have to be on them to freeze your eggs. Um, but I rarely ever see much difference after 1 month versus longer than that. So usually don't have people go off of it too much longer than that. Um, and I think another birth control pill questions, if you've been on the birth control for 20 plus years, you need to take more than a month off to be on the medicines. And for most people, no, that's why you can get pregnant pretty quickly after going off the birth control pills. But we usually have you, when you're off the birth control, also wait till your first natural menstrual cycle before starting. So if you get a period after a month, like right away after being back on, that shows that suppression is gone. You started ovulating regularly again. It sometimes your cycle might be a little bit more irregular. It could take a little bit longer than a month to get that first menstrual cycle back. But that's why I would say that month is a good marker, because when you get a period, that means you've ovulated again. But if it takes a month and a half, and after being off the pill to get a period, then you know your body maybe needed a little bit longer time frame. Most birth control pills nowadays are very low dose, where I actually would say it's more rare to see this big suppression from being on the pill. That I would say it's ends up being kind of a minority of people who really need like a bigger washout period from being on them. Um, any other questions? I think I answered all the ones that are in the chat now. If nobody has any more questions, we can wrap up. But obviously, if anybody does, feel free to enter. Or I can stay on for another, couple minutes just in case somebody wants to ask anything else. But if not, I hope we helped give some information, and I hope everyone has a great evening. All right, I don't think we have anybody's last minute questions, so I'm going to end the Zoom. Everyone have a good night.